Welcome to AETCM, the emergency medicine channel. Today I am presenting a case of 64 years old female who presented to our ear with complaints of shortness of breath on exertion, palpitations, fatigue and tremors of hands since 3 weeks. On initial 10-second assessment, she was conscious oriented, airway was patent, no pooling of secretions, breathing it was bilateral equal, chest movements and air entry was bilaterally equal, no added sounds. Respiratory rate was 22 per minute.
Okay.
Saturation 98% on room air. Circulation, heart rate was 116 per minute. Pulse was regular. BP was 150/90. At this point of time, IV cannula was secured and ECG was ordered. Disability, GCS was E4.
Respiratory system, air entry?
Air entry was bilaterally equal.
There was no crepitations?
No crepitations.
Okay.
Disability, GCS was E4, V5, M6. Pupils were bilaterally equal and reacting to light. Moving all four limbs. Exposure, GRBS was 220. Temperature was 36.7. Adjuncts of primary survey.
Okay, let's wait. Yeah. So, we'll just dissect from the beginning. So, we had a 64-year-old lady. Yeah. Okay. 64-year-old lady. Any comorbidities that she has?
Yeah, she's a known case of type 2 DM and DL.
Type 2 diabetes mellitus and dyslipidemia. So that is a risk factors. So age is a risk factor, and she has presented with history of diabetes and dyslipidemia. She has presented you with breathlessness. Breathlessness is her main complaint. So since when she is having breathlessness? Since last 3 days.
Since 3 weeks.
3 weeks she is having breathlessness. 3 weeks the patient is breathless. Okay, so it's not an acute disease. It's something that has happened over a period of time. So 3 weeks, whether it is the same or it has increased or decreased?
It has progressively increased.
Progressively increased since last 3 weeks. I just want to know whether there is any history of PND, orthopnea or any of these things.
It increases on lying down.
Okay. So there is an history of orthopnea is there. Okay. So there is increase of breathlessness since last 3 weeks. Orthopnea is there. Any other history that you were telling of palpitation? The patient was feeling palpitations. Since last...
that was the last 3 weeks.
Okay. What is exactly palpitation?
Palpitation is what the patient feels due to the increase
in the heart rate. Usually whenever the heart is beating, we are not feeling that. So whenever the patient feels that discomfort, that the patient herself is feeling that beating of the heart, we can call it as palpitation. What is the most common cause for palpitation?
Most common cause?
Most common cause that we all can have it in. It's anxiety. So anxiety will be the most common cause of palpitation. So anyone who is anxious, they can have this palpitation just before our exam result. You are watching a crucial cricket match or a football match. These are the time that you will be panic and anxious. So we'll have palpitation. So that is one of the most important reason. So most of the panic attacks, they will have this history. They will have frequent episode of this anxiety attack and all. But this lady is having since last 3 weeks, which is something very significant. So since last 3 weeks, somebody is having breathlessness and palpitation, we definitely need to evaluate. So with this in background, you have went ahead with the evaluation of her, and she's complaining of some tremors also. So these all things can happen for anxiety, but this long duration won't happen. So it will be episodic. So whenever the trigger happened, that panic attack or the anxiety comes and they will have those symptoms. But when it is happening in a continuous fashion, the most important thing from the history with the risk factors, what we need to rule out is an acute coronary syndrome. So that is the basic thing. It is a primarily when myocardial infarction or anything. As you rightly pointed out, we need to take a 2 lead ECG in this patient. So 116 is the heart rate that you have set, and it was regular in rhythm, which is very important. So regular in rhythm, 116 heart rate. So that is in the tachycardia range, and respiratory rate was around 22. So that is not very high. So 16 to 20, we can take it as okay, but it is 22. Maybe there is tachypnea is there, and her saturation was maintained, and the chest was almost clear. Suppose I am telling you rather than 3 weeks history, this is a sudden onset history. So what investigation you have taken an ABG? Okay, not for this patient. I am just assuming that the same patient had come to you within 30 minutes of this episode. You have taken an ABG. So, and what ABG finding will help you in saying that this patient is probably having a panic attack?
Because of the hyperventilation, she will have respiratory alkalosis.
There will be respiratory alkalosis. So most importantly, the PO2 will be normal, and there will be a lot of carbon dioxide washout. Maybe it will not have gone into the alkalotic range, but definitely the PCO2 will be low than the normal range. So that gives you, so that is respiratory alkalosis. Now we'll come back to this patient. This patient respiratory rate is on the higher side, and you have taken an ECG. What was the ECG finding?
ECG finding showed sinus tachycardia.
Sinus tachycardia. So when you name it as sinus tachycardia, it is clear each P wave is followed by a QRS complex, and it is a sinus tachycardia. The rate is less than 150, so it is a sinus tachycardia. So we are not dealing with any of those arrhythmia. Whether the most concerning part will be you are dealing with an atrial fibrillation. Since you said it is a regular itself, that time itself we have ruled out an atrial fibrillation. We wanted to know an SVT, but usually SVT heart rate will be above 150. So here it is 160. So most commonly it is due to a sinus tachycardia. So sinus tachycardia, reason we need to find out why she is having a sinus tachycardia. Any other STT changes in the ECG?
No,
like ST depression, ST elevation, nothing you couldn't find. You couldn't see anything. Left ventricular hypertrophy, nothing was seen. Okay. So that is the ECG finding. So the next complaint that what is breathlessness. So blood gas analysis was done for her.
Yeah.
What was the blood gas findings?
In blood gas analysis, the pH was 7.42, PCO2 was 32,
Okay.
and PO2 was 72.
PO2 was 92 and it was on a room air.
Yeah, it was
so it's a normally it's a normal ABG. So breathlessness, she was complaining, but ABG wise she looks okay. There is a PO2 of 72 and there is no much of an PCO2 retention, but there is a minimal carbon dioxide washout as shown by 32 PCO2. Fine. The next thing, what investigation? You got a chest X-ray for her?
Yeah, chest X-ray was also normal.
Chest X-ray also was normal. Then ECG normal, chest X-ray normal, blood gas analysis normal, and now you can continue with your adjuncts. So right now she is not in a life-threatening situation. She don't have any life-threatening features because her airway, breathing, circulation, everything is maintained. So we have time for other evaluation. We can go for a secondary evaluation. We can go to the next. Yeah.
In secondary survey, she is a known case of type 2 dyslipidemia. She was apparently normal 3 weeks back when she presented, when she had complaints of shortness of breath on exertion with easy fatigability. It was insidious in onset and it progressively increased to NYHA class 2, and there was no, it also increased on lying down.
Okay.
There are no diurnal variations, and she also gives history of palpitations since 3 weeks.
Okay.
She also complains of unintentional weight loss of 3 kg over 1 week, in spite of increased appetite.
Okay.
Her relatives also noticed tremors of hands since 3 weeks, which gradually increased, and also she complained of reduced sleep for the past 1 week. She also gives history of loose stools 2 to 3 episodes per day, and since 2 weeks, and she was also prescribed NSAID recently for back pain, and she had it for 5 days. There is no complaints of heat intolerance, any muscle weakness, hair loss, sweating. No history of any agitation, seizures or delirium. No history of trauma, burns. No complaints of fever, cough, dysuria, abdominal pain, vomiting.
Okay, that's fine. So just we'll take the positive history, whatever you have suggested. So 3 weeks since then, she has developed. It was a sudden onset 3 weeks. So from 3 weeks, it's gradually worsening. And now any edema, pedal edema history she is giving? No pedal edema. So most likely we are ruling out a cardiac failure. We are not looking in terms of anything, but there is some amount of orthopnea that we need to look in why she is developing this. So then the most important history that we got in here from positive things are, one is weight loss. 3 kg weight loss in 1 week is very significant. And there is history of loose stools. And there is significant tremors that has been noticed. So with this background, it is otherwise proven we have to look for a thyroid. That will be our next investigation that you want. So I am giving an option. Okay, you can only do one thyroid investigation for this patient. What investigation you will choose? I am giving an option. For any patient, you have suspicion of a patient with thyroid dysfunction, only one test you can do. Which test? So TSH is the only test that is required. So that with TSH, we can come to know, for this patient, I am not telling, we have to go for a free T4, T3, everything. But in a routine evaluation, you want to look for thyroid, TSH will give you an idea whether this patient is having a hypothyroidism, euthyroidism or hyperthyroidism. So what the most problem with the people that they don't understand, the TSHs is high. That means the patient is having hypothyroidism. So we need to supplement thyroid. So if the TSH is suppressed, that it is basically thyroid stimulating hormone. If TSH is suppressed, we need to understand that there is hyperthyroidism. There is a lot of production of thyroid is in excess. So we need to go ahead and suppress that extra production. So that is how we have to manage this patient. So that range will be varying from 0.5 to 4.5 depending upon lab to lab variation. And this is a question that been asked whether you need to check thyroid test in a fasting. whether you need to check thyroid in fasting or not. That's a question. Routinely, the most important thing that any other hormone test, there is a diurnal variation, there are certain hormonal tests that you are doing, but thyroid function test, whenever you're doing for the first time, for example, you're doing it right now at 8 a.m. So whenever you wanted to compare it next time, so do it in the same time. So suppose you have done investigation at 8 a.m. The next you wanted to compare the, suppose you have started the patient on treatment with Thyroid for hypothyroidism. The patient should be taking those medication, and on the day of testing also the patient should take the medication, and the same time we should be checking the thyroid. Whether we have taken it 4 p.m., we have to do it 4 p.m. So that is a simple logic behind thyroid testing. So whatever time you have doing, the same time it is preferably to check. If you have done at 10 a.m., you have to do 10 a.m., 10 p.m., 10 p.m. So that is a basic thing regarding thyroid. Ideally, fasting is not required. So whatever time you have started, you have to repeat. Now we'll come back to this patient. So you have taken an ECG, ABG and a chest X-ray. Next investigation, from the history, we have pointed out that probably this patient is having a thyroid. So from this, I want to do, you are going for a secondary examination. I just wanted you to look for any features of thyroid enlargement. Any features were there? Thyroid enlargement
I checked, but I didn't feel the enlargement.
You didn't see any enlargement. Any ophthalmic features of thyroid toxicity?
Also a bit of lid lag was there.
Okay. But that all within this 3 weeks, it is very difficult to develop. It takes a longer time. So within 3 weeks of time, you are not expecting any of these changes. So let's wait. Maybe later on, if the patient is not treated properly, she will go into all those phases. So now you have ordered for a thyroid TSH, free T4 and free T3. Why free? Free T4 and TSH is the most important investigation in this patient, but the circulating one, which are bound, we will not be able to know. We want to know how much is the free, which is roaming around in the circulation, which is causing all our symptoms. So that is what we want to look in for. So we want to look in for that, and our treatment strategy will be depending upon to suppress the circulating hormone. Already it is released in the blood, so we have to decrease that, and you have to decrease the further production also. So that is the basic treatment idea. So for that reason we will plan our treatment accordingly. So now this thyroid function test has been done. What was the TSH level?
TSH was 0.005.
So it is pretty suppressed. So 0.5 is the normal, it is less than 0.005. So TSH is significantly suppressed, stating that she is having hyperthyroidism. Now free T4 and T3.
T4 was 20.23 and T3 was 351.6.
Pretty high. It's very, very high. So what normal cutoff will be somewhere around 4.5, 3.5 for both of them. So it is almost very much high than the normal range. And suppose you imagine that this patient is only having suppressed TSH, but free T4 and T3 is normal. You want to do anything, not for this patient, some other patient you are routinely evaluating in your ED or whatever, somebody has sent a TSH and her free T3 and T4 is within normal range and TSH is only suppressed. You want to do anything and patient is asymptomatic. So that is called as subclinical hyperthyroidism. If the patient is not having any symptoms, you can just wait and watch. Even if it's a borderline increase, we can just wait and see and follow. But if the patient is symptomatic, definitely you need to treat in here. So this patient has got features. We cannot say that she is in thyroid storm as such, but she is in thyrotoxicosis. That we can say. She is in hyperthyroidism. Toxicosis she has not went, maybe, because there is no other toxic features. When you will say she is having a toxic features, thyrotoxicosis or thyroid storm, what should be the additional things that you should have?
Hyperpyrexia, high temperature.
Okay.
Tachycardia.
Arrhythmias. She can develop atrial fibrillations.
Congestive
heart failure features.
Then mental status.
Mental state. She has not gone into that state. She might go into that state if you are not treating right now. So maybe we can just call it as a hyperthyroidism, which we have detected. And if it is not treated, she will go into thyroid storm. So that is a phase by which we have come to. Now you will have to decide for the treatment. So before that, any other investigation that you wanted to send in this patient?
We'll check for the liver function test.
Yes.
It can get deranged.
Okay. Then complete blood count. Definitely we need to check in. Complete blood count and liver function test. These are the two investigation, and obviously other electrolytes. Just look in for whether there are any other electrolyte abnormalities. Just keep those things in your mind. See, hyperthyroidism definitely needs further evaluation. So the most important thing, the worst part can be a malignancy. So you want to look in for a malignancy. Definitely the treatment options and the treatment plan will be depending upon that further. And sometimes you need biopsy also, FNAC or biopsy, and sometimes total thyroidectomy is needed. So how will you plan an evaluation of thyrotoxicosis? This patient, what all treatments you will start immediately, and how will you plan your overall management of her diagnosis? You need to find out why she is having hyperthyroidism. Whether there are three possibilities that you need to consider: whether it's a Graves, whether it is a malignancy, or whether it's a viral thyroiditis. So these are our three possibilities. Whether there is a solitary nodule, MNG, or whatever be it, that is producing some extra thyroid hormones and that is creating a problem. So these are the three most common reasons. Graves, one of the most common autoimmune reasons, so it can appear at any age group. So Graves disease. Next will be a viral thyroiditis, and third will be malignancy. So how will you plan the management of this patient?
Initially, since the patient is having tachycardia, we will try to manage the rate. We can start a beta blocker.
Best agents are beta blockers. Among the beta blockers, the best agent is propranolol. So that is found to be very useful drug. You can start maybe 20 BD, 20 TAD or 40 mg. Depending upon the heart rate, you can titrate. That will decrease the symptoms. Also, it will help in the peripheral conversion of our thyroid hormone. So that is one thing that you need to start in immediately for her. And only thing, when you start propranolol, you have to look in for asthma history, because it is not a selective beta blocker. So it will block all those things. So there is no asthma history, beta blockers, propranolol is the agent of choice. All her tremors, everything will subside. Next.
If the patient is asthmatic, we can try calcium channel blocker.
Okay.
And
can even go to selective beta blockers also. Then, what are the other drugs that you wanted to give?
We have to suppress the thyroid hormone. I have to give anti-thyroid drugs such as thionamides like propylthiouracil,
or carbimazole. So these are the two agents that very commonly used. Yes. Carbimazole, we might need to start 20 to 40 mg TAD doses, and we need to look in for that is the reason why you have asked for an LFT and your total count. Yes. So neomarcosol can sometimes suppress your total count, and also the LFT can get deranged. So we should know what is the baseline. So the most commonly used drug is neomarcosol initially. Initially you need to titrate and you need to look for the response. Usual response, it will take at least 2 weeks for the 1 to 2 weeks for the response to happen. So the TSH suppression will take a longer time, but free T4 and T3 will start coming down once you start your beta blocker and all those things, because already there is a circulating hormone, so that you need to suppress. So the role of steroids.
Steroids also reduces the peripheral conversion.
So again, steroids can be used. So hydrocortisone can be used in this patient. 100 mg TAD you can give in this patient also. So these are the three agents that you need. Then now you have to decide any role for this lugolcidine or other iodine solutions that you need to give in here. So routinely, if it is very, very refractory, we can think of maybe sometimes you need to take in for an urgent nuclear ablation scanning, nuclear lugolcidine, and by asking them to take a radioactive iodine treatment. But usually by this three measures, that is giving steroid, giving a beta blocker, and starting an anti-thyroid drug, usually that part will be subsided, and we should find what is the cause behind this. So for that reason, the first investigation that you need to send is what is the further investigation that you should go for?
First, we can roll out Graves by sending the antibody thyroid.
That takes 4 or 5 weeks.
Scan.
Which scan?
Radionuclide.
It's a radionuclide scan. What is you are saying is right. You have to go for a thyroid nuclear scanning. So technician scintigraphy, thyroid technician scintigraphy, or whatever it is available, you should go for that. So depending upon the uptake, you will know whether there is significant uptake, whether there is decreased uptake, whether it is a normal uptake, whether it's a diffuse uptake, whether there is only uptake in one part, then it is malignancy. What will happen in viral thyroiditis? What will be the uptake?
No uptake.
Viral thyroiditis? It can be no uptake. You're right, only no uptake. Sometimes, but in Graves, usually diffuse increased uptake, but even it can be a normal uptake also. When it is an early part of Graves, it can be a normal uptake also. So most important thing why you want to do a technician scintigraphy, you want to see any nodule which is very active. Also, you can do an ultrasound, you can look in for different nodules and all. But if you are seeing an active nodule, definitely that needs biopsy, and definitely maybe a definitely treatment like a total thyroidectomy is mandatory. And another thing is that when you are starting this anti-thyroid drug, also you need to look in for what are the other, you said TSH receptor antibody. That is the one investigation that you can do. Look for the confirmation of thyroid, and TPO. That is the another investigation that you can say. The most common will be Graves. So what will be the treatment plan for these patients? So this patient, when she is ready to get discharged, when you will say that okay, she can go home. So when you are seeing a rapid decrease in TSH, rapid decline in free T4, T3, and her symptoms are better, she can, because all oral medications only you are going to give, because neomercazole is an oral medication, and you can give even steroids orally, even if you can give beta blockers orally. So once she is okay, another 2 to 3 days, her symptoms subsides, her heart rates comes down. You target an heart rate less than 90. If 80 around, that is well and good. So that range, if you are able to get those patients, you can ask them to come back, and you can need to review after 2 weeks and see how the free T4 and TSH is responding. If TSH free T4 is still elevated, you need to increase your dose of neomercazole. So like that, you need to increase, and maybe you need to taper down. But you have to understand that in Graves' disease, they needed to be on some anti-thyroid drugs. Either they should be on neomercazole for some, previously the teaching was you have to give for 18 months. Neomercazole you need to give 18 months. Then you can see whether there is any chance of the disease going into suppression, but there can be remission phase, all those things can happen, but the recurrence also is a possibility. So now there are recent study, before and all neomercazole they previously didn't used to give for a longer time. Now there are longer studies that you can give for years together, like 10 to 20 years. Patients are on small dose of neomercazole, like 2.5, 5 mg, 10 mg. These are all very small doses of neomercazole. That is carbimazole. The patient can be on these drugs. They can continue, but otherwise they have got two options is available. One is total thyroidectomy, and the next one is radioiodine therapy. So that again, if the patient is going for radioiodine therapy and surgery, they should be on thyroid replacement with thyronone tablets. So here what you have seen, a 64-year-old lady who had presented with palpitation and with 3 weeks history and with history of breathlessness. On clinical examination, except for the tremor, we didn't see anything much. The chest was clear, the heart rate, there was some amount of tachycardia. But with the history of loose stools and all, we got suspicion of hyperthyroidism being one of the reason, and you went behind that. Any drugs can cause hyperthyroidism that we commonly use in ED. Amiodarone is one drug that we commonly use that can cause hyper and hypothyroidism and also lung fibrosis. So amiodarone is one agent that we commonly use in the ED, can cause these things. So anything else that you need to add on?
His SGPT value was also raised. He also had a transaminitis.
Okay. After starting neomercazole or before that?
Before that itself.
Okay.
So, it can indicate Graves.
Okay. Fine. So how is she right now?
Right now, we discharge the patient on oral medications.
Okay.
With neomercazole and low dose. Because of the transaminitis.
Low dose. But that is the one problem. Beta blockers will take care of her symptoms. But to her control of her anti-thyroid activity, we need a good dose of neomercazole, like 20 mg TAD and all. But because of transaminitis, we might not be able to go ahead on that. So we need to have a close watch on your SGOT, SGPT, and we need to avoid all other agents. If the patient is on dyslipidemia, she might be on some statins. We need to stop that statins. Metformin, if she's on diabetes, she's on metformin, we need to stop those drugs. So we need to look in for why she has developed this transaminitis. It can be the most commonly the patient is on atorvastatin. That atorvastatin can be attributing to this. So we need to stop those agents also, and we need to look at maybe just a fatty liver, underlying a fatty liver which is causing this OTPT elevation. That also we need to target. So in a nutshell, when a patient is coming with you are suspecting a thyroid disease, do a TSH. So by doing a TSH, if it is suppressed, you are looking in terms of hyperthyroidism. If it is elevated, you are looking for a hypothyroidism, and you plan your management and investigations accordingly. Okay, fine.
Thank you.
Thank you.